organizing this program, and thank you for everybody who gave up their Saturday morning to be with us. I hope that it's a productive morning. So I'm going to be speaking about perimenopause and menopause. I have no financial interests or disclosures. I will be talking about certain pharmaceutical devices and drugs, just so you can be empowered to ask your physicians about this or to do your own research, but I don't endorse any particular product. And the purpose of this engagement is to increase basic knowledge of women's health. I do a lot of these talks throughout the community, and I educate medical students and residents because I think it's important. And I think women's health is in general not valued as much as it should be. So I try to get the information out there, but I encourage questions. You can send them in the chat if you have them. But again, this is by no means a replacement of your care. So if you have any issues arising, medical concerns, please contact your physician directly. So this is our basic agenda. So I'm going to introduce Mountainside a little bit, talk about what we offer. I'll speak on menopause and hormone replacement therapy. And I'll briefly touch on hypothyroidism, heart disease, and osteoporosis. This could be several hours. Each of those topics could be several hours in themselves. So we're just going to gloss over it. If you have specific questions, I'm happy to answer them if you want to email me afterwards. We'll do a meditation video. Dr. Anjali Grover couldn't be here today. She's an endocrinologist, but she's a wonderful practitioner of Mountainside Medical Group, and she offered a meditation video because we all could use some self-reflection and mindfulness. Then Tara Fries will speak on behavioral health, and Elena Mills will speak on nutrition. So this is just my background. I don't need to read it for you. I'm a private practitioner. I work for Mountainside, and my office is in Nutley. I've been in Mountainside for 3.5 years now. I've been in practice for 5 years. I did my residency at St. Barnabas Medical Center, and I stayed locally to practice. And I'm involved with medical student resident education, nursing education, and I'm the president-elect of the New Jersey OBGYN Society. So we bring the concerns of our patients and our fellow practitioners directly to the legislators. So, you know, if there are specific concerns, we're always trying to fight on the front lines for women's health. I'm also involved with the American College of Obstetricians and Gynecologists, which is our governing body who guides our clinical practice, and I'll get into that a little bit more. Tara is a licensed clinical social worker and has been part of Mountainside medical staff for over 4 years. At Mountainside, she has worked in the behavioral health inpatient unit as well as the outpatient department, and as a crisis counselor in the emergency room, working with adults, families, and children dealing with mental health issues. She received her master's degree in social work from Rutgers University and an undergraduate degree in business administration and finance from the University of Delaware. Prior to her social work career, Tara worked as a forecast manager for Levi Strauss & Company. As an active member of her community, she is a local Girl Scout troop leader and heads the annual book fair school fundraiser. So thank you, Tara, for being with us today. I look forward to your talk. And then Elena is a graduate from the Montclair State University and is a registered dietitian nutritionist. She creates and presents nutrition, health, and wellness programs to diverse groups, organizations, and individuals with a wide array of health and wellness concerns. Elena has worked in numerous settings, including acute care, inpatient medical nutrition therapy, cardiac rehabilitation, and oncology outpatient counseling, community health outreach, and clinical nutrition management in the continuing care and long-term care settings. Elena's passion lies in empowering individuals and families with tools, motivation, and support to treating acute and chronic conditions, resulting in improvement of their health and wellness. Currently, she holds the role as clinical nutrition manager with the Food and Nutrition Services team in Hackensack Meridian Health at Mountainside. We're very fortunate to have Elena as well. We know that both mental health and nutrition encompass every aspect of medicine. So I really am very privileged to have these ladies speaking with me today. So just a little bit about Mountainside. We know it's part of the Hackensack Meridian Health System, and we're a member of Ardent Health Services. We're your local community hospital. It's a premier local maternity center, but we're not going to be speaking about the babies today. But there is a diverse specialized gynecological program. We offer gynecological gynecology emergency services, gynecological surgery, including minimally invasive laparoscopic and robotic surgery. We have the new robot and console, gynecological oncology, and if necessary, radiation oncology and medical oncology. Urogynecology is pelvic floor medicine and reconstructive surgery. Adolescent gynecology, women's well care, menopausal management like today, infertility and treatment of a variety of conditions. We have a really great pre-admission testing program for patients who need to have procedures done at Mountainside. Everything is done right there. And because I work for the hospital, we have the same EMR. It's very streamlined. It takes the patient responsibility out where you can just worry about being safe and healthy and showing up for your appointments. And we can do the back work for you. We have high quality screening, mammography, ultrasound, X-ray, MRI, and CAT scan. And they also do specialty tests that some of the local imaging places do not do, like hysterosalpingogram, where we're actually looking, it's a special fluoroscopy radiology image that looks at the health of your fallopian tubes. This is mainly for fertility and pelvic pain. And then also saline sonohystogram is another special ultrasound that we offer at Mountainside that helps with fertility and women with abnormal uterine bleeding. Mountainside Medical Group consists of 4 OBGYNs, several primary care physicians, and a variety of specialists. So I'm by myself in the Nutley office. And then there are 3 practitioners in our Cedar Grove office, Dr. Robert Montemuro, his daughter, Dr. Daniela Montemuro, who I did residency with. They're both lovely physicians, and Dr. Peter Warwick. Dr. Warwick comes from a long line of obstetricians, and he's awesome as well. Many of you may even have him as your physician. So special thanks as always to Fulare, our community health manager. You really bring so much to the hospital, and they're definitely not recognized enough in serving the people of our area. So thank you so much again for organizing this. This is just some WebEx etiquette. Again, you know, you can leave the video as needed if there's a topic that maybe you're not as interested in. I think all the topics are really worthwhile today, so I hope you can give us the time, that we totally understand that your lives are busy. So that's why we have the agenda. You can refer to that. Please mute yourself during the seminar unless you're called upon for a question. If you wish to ask a question, please send a chat message and we can address that at the end of the talk. And then we'll have a little Q&A session. The biggest thing is just really having fun and learning something today. Hopefully you'll each take away at least one message. So the American College of Obstetricians and Gynecologists, like I said, they're our governing body. They are a national organization, and they tell us basically there's different committees, and some that I'm on myself. I'm on the Fetal Alcohol Spectrum Disorder Committee. I'm on the District Advisory Council for New Jersey, Pennsylvania, and Delaware. And we get together and we really talk about what we're doing, how we can improve on it, what what the guidelines are, because we have to practice evidence-based medicine. These are the core values of ACOG, really trying to give care access for all women. And we want them to have high quality, safe healthcare. And again, that's based on evidence. And it also, ACOG is responsible for educating us. I'm a board certified obstetrician gynecologist. The American Board of Obstetricians Gynecologists is under the board of ACOG. So it was founded in 1951. There's greater than 58,000 members. There's 12 districts. We're District 3, so New Jersey, Pennsylvania, and Delaware. We get together very frequently and have meetings. And then we work with other organizations. Like I said, I'm the president-elect of the New Jersey OBGYN Society. We have A1, our nursing societies, midwife societies, CDC, and we form guidelines for clinical practice. This is the executive board. I really wanted to talk about ACOG because they just spent 2 years revamping the website. And if you go to ACOG and right up here on for patients, so it's www.acog.org/women's-health, you can go on and find evidence-based explanations for things. I always say Dr. Google is not your friend. I really want our patients to be empowered. However, sometimes not all information out there is good. Facebook chats, local groups, they're really not the answer. It's not to knock Facebook, but those aren't the places to get your guidance from. Your doctors are qualified and board certified, and we do continuing medical education, your other providers as well. And that's who you should be getting the information from. And they should also be telling you that you can go to other websites for follow-up. So you can, you know, outside of the provider's room and outside of the office, you can read up on maybe a condition or something that's going on with good resources. So this is really the mainstay, and it's evidence-based guidelines. We're going to talk about management of menopause. So I'm going to focus on sexual health and severe medical comorbidities associated with the menopausal transition. Again, for the sake of time, it's going to be glossing over some of the topics, and but I hope that if there's something that you have a question on, you'll just direct it to me. So we're going to summarize the hormonal changes characteristic of the menopausal transition. We're going to talk about a sexual dysfunction in the menopausal patient, identify the appropriate candidates for hormone replacement therapy, because depending on certain conditions or certain medications that you're on, you may not be a candidate, or there may be better options for you that you weren't aware of. And we want to differentiate between traditional and non-traditional menopausal treatments. So you hear patients say, I'm so hormonal. Like, what does that really mean? We all have hormones going throughout our bodies, and it's a really interesting pathway that starts in the brain. And hormones play a key role during all parts in women's life. So what is a hormone? It's a regulatory substance which is made in the brain or glands and is transported in tissue fluids like the blood to stimulate specific hormones. So it all starts in the hypothalamus and then the pituitary gland. That's what these little arrows are representing. I apologize if you can't read it, but the hormones actually start up in the brain, and the signal goes and they're transported to the other organs in the body and tells them how to function. And if something along the pathway is blocked, then it could create a problem for other things down the pathway. So for instance, if you have abnormal periods, it could be that your thyroid is under functioning. So we have to tackle the thyroid, and that may in turn fix the periods rather than just focusing on the ovaries. So as an obstetrician and gynecologist, I'm also a primary care provider, and I have to look at the whole body. And I work very closely with our endocrinologists like Dr. Grover, who helps us, you know, find out why something's not functioning quite effectively in the body. So again, this is just, you know, the different glands in the body. So the hypothalamus, that's in the brain. Pineal gland is in the brain. Pituitary gland is in the brain. And these are the hormones that they release. And the thyroid works in hand with them. And these are the hormones that are released by the thyroid. So it's a very, very complicated system, but it's very interesting. And sometimes there's positive feedback where one is released and then it causes the release of the other. And then there's also negative feedback where one is released in maybe high levels and it actually blocks the precursor before it. So that is applicable in menopause, which we'll get to. So estrogen, it's a vital hormone and has many roles in the body. You can see that in the little image there, there's effects in the brain, heart, liver, breast, ovary, uterus, vagina, and bones. So follicular stimulating hormone is the precursor. It's made in the brain and causes the estrogen to be released by the uterine lining, your endometrium, that's what sheds every month, and the ovary. And estrogen has many other effects on the body, as I've said. It can stimulate the development of the breasts. It helps with getting puberty underway. It's protective for the heart. It's protective for the bones. However, too much estrogen is not a good thing, and too little estrogen is not a good thing. So balance is really key. Progesterone, I always refer to progesterone as like estrogen's little sister. It's the counterpart to estrogen, and its precursor is luteinizing hormone. So it's made in the brain and causes the progesterone to be released by the ovary. It also helps to thin the uterine lining, and it's the predominant hormone right before you get your period. It's also progesterone is predominant in pregnancy. It establishes balance, and it's a key role in the menstrual cycle and maintaining maintaining pregnancy. So the menstrual cycle, a lot of women are not taught about their periods. I know I wasn't. I mean, I had a health class back in high school, don't really remember much from it. So when I see a patient in the office and they're having some sort of bleeding dysfunction, I want to talk to them about it and say, like, what is the menstrual cycle? Like, what does this bleeding mean? So menstrual cycle is cyclical bleeding. It should be every month. you should get it about the same time within a week. Typically, day one that you bleed is day one of your cycle, and women bleed usually 3 to 7 days. If it's less than 3 or more than 7, it may need to be investigated. Mood changes in pregnancy are due to hormone changes. Mood changes in your cycle are due to hormone changes. It's a decrease in estrogen and progesterone and causes an imbalance in the chemical serotonin. So what happens is the first day of your period is the first day of your cycle. You bleed 3 to 7 days. Then the follicular stimulating hormone kicks in, releases estrogen, and it makes the lining all nice and cushiony inside, preparing for an embryo. Then your body temperature drops briefly. Then there's a big spike in the luteinizing hormone, and your body temperature goes up. You ovulate, where you release an egg every month. And that second part of the cycle never changes. That's always 14 days. So if you don't get pregnant, 14 days later, you have a period. If you do get pregnant, 14 days later, you are pregnant. That first part of the cycle is what can fluctuate. So women who have a 21-day cycle, that first part is short. It's only 7 days. Women who have a 35-day cycle, that part is longer. So that's 21 days, because that second part always is 14 days. So this is very important for women who have abnormal uterine bleeding. Some women, they get pain during ovulation halfway through the cycle. They can get bleeding during that for a couple days. There are a variety of medical conditions that can cause abnormal uterine bleeding. Women who are getting to be menopausal, if they're perimenopausal, then they may have abnormal cycles, and we'll get into that. And that's why I'm kind of prefacing it with all of this information. And then polycystic ovarian syndrome, that's when patients don't ovulate. So they're skipping months at a time because their body loses that hormonal signal to ovulate, and their lining just keeps building and building on itself. And that can be potentially very dangerous. Other women have very heavy periods. 70% of women have fibroids. They're benign tumors in the uterine wall, and they can cause a lot of pain and bleeding. And around the time of perimenopause and menopause, it can cause problems for the patient where they can become anemic. They could require surgery. Some women have polyps in their lining, which are just overgrowths of the lining. So if the uterine lining looks like this, and a polyp is coming out, it increases the surface area of the polyp, and you can have a lot of heavy bleeding. And then some women have an unstable uterine lining because of hormonal changes, and that's the mainstay of this talk. So I think I'm going through menopause. How do I know? So perimenopause is characterized by irregular menstrual cycles. Some women, it occurs in their mid to late 40s. Some women don't get a period and then they never get a period again. They're the lucky ones. But most women, they're like, oh, my cycles have gotten a little bit irregular. Maybe they're bleeding every other month. Maybe they're bleeding mid-cycle too frequently. Maybe their, pain is more severe. Maybe their bleeding is more severe. So you have to keep in mind what's going on with the menstrual cycle. And that's why it's important to track it, not just for pregnancy. A lot of women get vasomotor symptoms, hot flushes or hot flashes. And this can be earlier if premature ovarian failure. And like I said before, we have to be cautious during this time for anemia. So if a woman's getting a period every 2 weeks, they can become severely anemic. If they're getting no period for 2 months and then they bleed for a full month, they can become severely anemic and require surgery. So we see the incidence of hysterectomies and other types of surgery going up during this time. And sometimes it can be managed by medication. So these little, hopefully I'm not offending anybody, little cartoons, I thought it was some good comic relief, the 7 dwarfs of menopause. And then this one, if I want a rapid heartbeat and need to get all hot, I only need to wait for my menopause symptoms. I thought they were cute. Menopausal transition. So menopause is actually achieved after 1 full year without a menstrual cycle. So if women are still getting their period and they're getting hot flushes doesn't mean menopause. It may mean perimenopause, but it doesn't mean menopause. The average age is 52. It previously was 51. Women are living longer. They spend a higher percentage of their life in menopause. They may spend 40% of their life in menopause. So we can't just, have your kids and never go to the gynecologist again. Some women do that because they don't think that their gynecologist will help them, and that's unfortunate. And we as gynecologists need to step up and have that discussion with our patients. There's a lot of feedback. If you don't mind just muting yourself, please. So we have to consider, like, just because you had your children, just because you're menopausal doesn't mean that you shouldn't still go to the gynecologist. So surgical menopause occurs after a surgery. Now, another misnomer is hysterectomy. So the word hyster, the preface hyster, means uterus. So hysteroscopy is a camera inside your uterus. Hysterectomy is taking out your uterus. It has nothing to do with the ovaries. And I say this because a lot of patients come to me and say, I had a partial hysterectomy. They left my ovaries. Has nothing to do. If you have a total hysterectomy, your uterus is taken and your cervix is taken. If it's a partial hysterectomy, which is also known as subtotal or supracervical, that's just the uterus taken, but the cervix, the neck of the uterus that connects the uterus and the vagina, is left behind. If the ovaries are taken, that's called an oophorectomy. If the fallopian tubes are taken, that's called a salpingectomy. So now, you have to find the right candidate for what they need done. If a patient has a need to take their ovaries out, that stops the hormones and drastically makes them decline, where women can go into menopause surgically within a few days of surgery. So that is usually very abrupt. Some women leave the hospital and they're already having hot flashes, and it's tough on a woman rather than allowing them to go through a natural menopause. But there are certain indications for having your ovaries removed, and that would be discussed with your doctor. Premature ovarian failure is when patients actually go through menopause less than 40 years old. It's also called primary ovarian insufficiency. Early menopause is 40 to 45. Late menopause is after 54. It tends to run in families, so it's not always something we talk about with our families, or maybe your mom and grandmother had hysterectomies, so you don't know when they went through menopause, but it's important to try to get your family history. It marks a loss of ovarian function, and it's marked by decrease in estrogen. So what happens is, normally the FSH is released and it releases estrogen. But when the FSH is released in high amounts, it actually blocks the release of estrogen. So this is what I was talking about with negative feedback. So that's why the hormones are important to check if we think a patient is perimenopausal or menopausal. Menopause can be characterized by irregular menstrual cycles, as I said before, hot flashes, vaginal dryness is a big concern, decreased libido, painful intercourse, and urinary tract infections. And it's a tough thing for a woman to go through. Maybe they have a wonderful relationship with their partner and they want to be sexually active, but it's too painful. Some women, will continue to be active because they feel that it's their duty. And that breaks my heart, because I want patients to enjoy their sex lives as well. So it's important for obstetricians and gynecologists to bring up talks about sexual health, because it can be, a tough topic. But I think that if you can't trust your gynecologist, you need to find a new one. I think that, there are things that we're supposed to bring up with you. And I was reading an article a couple of years ago that said 80% of women said if their doctors would just bring it up, they would discuss it. So definitely don't feel shy to discuss it with your doctor. There's also some serious concerns in this menopausal transition: heart disease, hypothyroidism, and osteoporosis. So estrogen is cardioprotective. It protects the heart. Estrogen is bone protective. So that's when we start to see heart disease. It's usually about 10 years later than when we see it in men, because the estrogen goes down, and that's when we see heart disease show up in women in their 60s. Osteoporosis, usually get a bone density scan around 65. But if you go through primary ovarian insufficiency or premature ovarian failure, you probably should get it sooner. Reproductive aging. So women are born with a finite number of eggs. We do not make eggs daily as men make sperm. So by 20 weeks gestation, when we are in our mother's uterus, we have 6 to 7 million eggs. By the time we're born, we've lost approximately 4 million eggs just by being born. By puberty, we only have 300,000 to 500,000 eggs left. And we ovulate 400 to 500 in our life. So when I was saying we send out our best egg every month when we ovulate, we also lose 4 to 15 other eggs per cycle. And that's by apoptosis. So it's programmed cell death. It's the eggs that aren't as good know to just kind of die and resolve. So by menopause, we only have 300 to 400 eggs left. And usually the egg quality is not great at that time. And that's all with the decline in estrogen as well. This is some of the blood work that may be done on you. FSH is follicular stimulating hormone. Estradiol is estrogen. So if you're still getting periods, day 2 or day 3 of your cycle is important to test this. If you're not getting a period or it's irregular, you can do a random one. It may not be as helpful, but they fluctuate based on where you are in the cycle. LH and progesterone, we'll see declines in estrogen and progesterone during this time, and also free and total testosterone will usually see a decline in them as well, and that could show the decrease in libido. And anti-Mullerian hormone for patients who maybe are thinking of having a child later in life and they're still menopausal or they're perimenopausal, we may check an anti-Mullerian hormone to see how much egg reserve they actually have and how they'll respond to any sort of intervention. So as I said before, premature ovarian failure it tends to run in families. The incidence is 1% less than 40 years old. So it's very rare. 0.1% less than 30 years old and 0.01% less than 20 years old. So it's rare, but it can occur. These are some of the causes, but most causes are unknown. Diagnosis: abnormal cycles. So if you're not getting a period for 4 months, and you're not on any medication, not on birth control, because we know that birth control pills can thin your lining, so you may not get a period, that's okay. But if you're just randomly not getting 3 to 4 periods, because we take our periods like 3 months at a time, then you should have a workup done, an ultrasound, you should have blood work done. If you're experiencing hot flashes, vaginal dryness, mood changes, those are things that you should talk to the doctor about, especially if it's early. And we have to do the hormone levels 2 months apart. So one may just be a false read. So we do it and then we repeat it again 4 weeks later to confirm the diagnosis. Hot flashes, that's usually the most common complaint of menopause. It's a sudden, intense rush of heat. So patients will be like sitting there doing their work at their desk or in the car with their family in the middle of winter, and they just get this intense rush of heat. Usually comes from inside up, chest, face, neck, very, very hot. A lot of these women have to dress in layers because they don't know when it's coming, when it's not. Some women say they get 1 a day, some get 20 a day. It can occur both at day and night. Some women say, I'm freezing my partner out because it's the winter and I have the air conditioning on. I have to dress in layers. I wake up in a pool of sweat. Those are things that, you should be communicating with your doctor. Some women also can get extreme anxiety around this time and palpitations. Some women have none, and those are the women who I say, be quiet. You don't want the woman next door to hear you, because you're very lucky that you're not having these. The average is 7 to 10 years. I remember my first talk ever that I gave, I said this and a woman yelled out, "You're a liar." And I said, oh my goodness, I was taken aback. But she said, I've been going through this for 20 years. So some women do have it longer, and that's unfortunate. There can be other things that cause hot flashes, particularly night sweats. So I don't want to scare anyone, but if it's coming out of the blue, it can be associated with certain types of malignancies, with cancers. So it is something to bring up with the doctor. But hot flushes related to menopause are not dangerous. Vaginal dryness is a big problem with perimenopausal and menopausal women. Even if you're still getting your period and you're in your late 40s, then you still can have problems with vaginal dryness. There's a decreased estrogen, so less blood flow to the vulva and vagina, less collagen and elasticity. So actually the tissues thin out. You can see on the bottom there where the tissue looks very thin. There are other conditions like lichen sclerosis. They actually thin the lining out and can cause, they can be precursors to vulvar cancer. So if your doctor sees this, they may want to do a biopsy to see what's going on. And some women get the sensation of a yeast infection, like itching and irritation all the time, but there's no yeast. It's from the thinning out, the less collagen, less elasticity, less hyaluronic acid. You can also get disrupted pH. Our vaginal pH is very acidic, so it's 4.5. But because of the pH imbalances, you can get bacterial vaginosis, which is basically when the good bacteria gets wiped away and Gardnerella bacteria grows up. It's that kind of smelly, thin, grayish yellow discharge that it's usually from getting soap inside or over cleaning. So wipes are really not your friend. I tell all my patients to stop using wipes. You really don't need to be wearing pads or panty liners all the time. It traps moisture and heat unless you're having urinary leakage, and I really wouldn't be wearing a liner every day. Or a panty shield or anything like that. It also can give less protection against pathogens. You can get more UTIs, more yeast infections. It's just a more fragile area. And the nerves are disrupted because of the androgenic effect and the decreasing estrogen. So some patients just touching it or having intercourse, sometimes even wearing their clothes or tight jeans, that can really irritate them. They're like, I can't even sit down anymore. And it really can take a toll on their life. So it's important for you to talk to your doctor about that and for us to ask you. Weight gain. So I'm not going to talk much about weight because I know we have the nutritional talk, but a lot of times it's aging and lifestyle. Women are becoming less active. The fat distributes differently. They might get abdominal girth, like a larger belly. And then the fat around your organs does increase around this time. And obesity can bring serious consequences. But again, because we have the talk later and for the sake of time, I'm not going to get too much into this. You can also get mood swings and irritability. So the luteal phase, that second part of the cycle, actually becomes longer. They get these irregular cycles, so you get more like premenstrual symptoms and for a longer period of time. So patients notice that. Also, hormonal fluctuations, because of the lack of estrogen, it can mess with the serotonin in the brain and your mood stabilizers, essentially, and it can cause mood swings. And again, we're going to have a talk on behavioral health, so I'm not going to get into that too much. But these are things you should be talking to your therapist about, your OBGYN about. Sleep disturbances, so lifestyle patients I had a consult with a lovely patient yesterday. She said, I get up at 2 o'clock in the morning every day and I can't fall back asleep. I go to bed at 10. I don't want to take sleep medication, which I understand. You should really try not to have patients take sleep medication for more than 2 or 3 days. It's not something that you really need to be on long term. There are side effects, and a lot of women have decreased sleep. They have increased cortisol. They can have hypothyroidism, lower leptin, also can cause increased weight gain, and they can become more insulin resistant. So they can't fight sugar as well, and it can affect their sleep. So some non-hormonal treatments, this is usually what we start with first. So some patients or patients who aren't candidates for hormone replacement therapy. So actually 2 of the antidepressants, so Paxil, Bristol, and Effexor, they actually have shown to be effective for vasomotor symptoms of menopause. So if a patient can't take a hormone or doesn't want to take a hormone, then this is an option for them. Gabapentin and Neurontin are usually used for nerve pain. They can also be used. There are some quote unquote natural therapies, but natural doesn't always mean safe. So anytime you go to your doctor, you need to tell them what herbals and supplements and all of the vitamins you're on, because they can affect your blood pressure. Sometimes they can interact with other medications you're on. But these are some of the things that have been used. So like soy has estrogenic properties. That's why men who are having problems with fertility are instructed not to eat soy. Estrogen is over the counter, black cohosh, various Chinese herbals. The studies really show that they don't work, except there's one Chinese herbal in conjunction with acupuncture that has been shown to work. And then there's other things like ginseng and St. John's wort, things that can boost your mood, can boost your energy. Vitamin E has been linked to helping with decreased libido. So those are things that you may take as a supplement. But again, you should always speak to your provider first. And then the bioidentical hormones, that's always the new hot topic. They're actually made in a compound pharmacy. There's like specialty pharmacies where people compound the medications. There's limited efficacy, though, to them. I have patients who swear by them. Even though black cohosh hasn't shown to work, I have a patient who says, I don't care. Black cohosh and a multivitamin has changed my life. Now, I don't know if she just transitioned out of menopause or it really does work for her, but who am I to tell her? As long as it's not causing harm to her, her blood pressure is stable, and I'm monitoring her, I'm fine with it. But it's about the patient and physician relationship. Bioidentical hormones, they're not all created equally. So there are great compound pharmacies out there, but what can happen is sometimes the medication is not compounded equally each time. And really the studies have not shown in a large volume that they're actually efficacious, but there are a lot of women using bioidenticals. Again, there are a lot of people out there who will say, I'm a hormone specialist, come to me. There's a lot of ads, and women who are going through these times get frustrated and they're like, well, I'm going to go to whoever can help me. And sometimes they're led in the wrong direction, and then they can have irregular bleeding or they can have problems with their blood pressure. So really just bring it up with your OB/GYN and talk to them about what your concerns are and see if there's some options for you. Pellets, sure, Real Housewives and other shows, you've seen it on there. So bioidentical hormones, they come in a variety of forms. You can do pills, sprays, gels, and now they have pellets that are actually inserted underneath the skin. Estrogen and testosterone. Progesterone is still given topically or orally. And the effect occurs within 48 hours and lasts between 3 to 5 months. Men get pellets too, they get testosterone pellets, but these really have to be really watched. I've seen patients' levels go through the roof, and I've seen patients' blood pressure go through the roof, or patients have postmenopausal bleeding because of them. So there are, if a patient really is doing well with them, I will help. I don't do them myself, but I will help them be monitored. They have to check the hormone panels frequently and before giving another round. Non-hormonal vaginal dryness therapies. So this is like the mainstay. Some women, all they have is vaginal dryness. They're like, I have a hot flush every once in a while, but this is the worst. I can't have intercourse with my partner anymore, or just everyday dryness. So vaginal lubricants, water-based or silicone. Water-based, like your KYs, the Astroglide, those types of things. Silicone, there's like Uberlube. There's a lot of different great, companies out there. And there's no shame in using a lubricant. I have my 20-year-olds using lubricants. Patients who are on birth control for long periods of time can actually get vaginal dryness, even though they're not perimenopausal or menopausal, because it raises what's called the sex hormone binding globulin. So if that's a consideration, there's no harm in using a lubricant. Some patients use coconut oil or other oils. You just have to be cautious with it. If you have sensitive pH, you may get repetitive infections. Vaginal moisturizers, pH balance agents, gels, and probiotics. There's a lot of different inserts. Hyaluronic acid decreases during perimenopause and menopause. So like something like a Reverie to replace the hyaluronic acid can help. It can be expensive, but you can get that. And I would be cautious, because I know you can go on Amazon or on the internet and buy everything, but discuss it with your doctor first. And then there's laser therapy. So there's a very expensive laser machine that actually does like vaginal rejuvenation. However, it's not just for your partner, it's for you. It's for your vaginal rejuvenation. So you're not having pain. They've been doing studies for lichen sclerosis with it as well. Only I know a few providers who do it. If somebody's interested, I can give you a name. It's like a $200,000 machine. It's very expensive, and you need to go anywhere from 3 to 6 times, and it's usually not covered by insurance. But some women, if they've exhausted their options, they'll go. The hormonal therapies, like estrogen creams, Estrace and Premature are two of the most popular, and there's vaginal inserts that you can use. They actually are placed in a very strategic way based on if the patient has a uterus or not. So the creams really, even though the gels on the skin are systemic, like they go throughout your whole body, the creams actually aren't systemic. They have very, very traceable amounts of hormone throughout the body. So these are really safe options that you can discuss with your doctor. I've even given it to patients who've had a history of breast cancer after they're out of their window, because it really doesn't systemically absorb. So the one concern, though, is if the patient has a uterus with a lining and they just take the estrogen therapy not as directed over and over and over again for long periods of time, then you theoretically could build your uterine lining. And if you're menopausal and not getting periods anymore, then that can be problematic, because that unopposed estrogen, too much estrogen, again, is not a good thing, and that can cause abnormal or even precancerous cells. So hormones get this really bad rap, but you have to realize when used appropriately, they can really change someone's life. So typically what I do is I'll have a patient insert it once at night for 2 weeks, then every other night for 2 weeks, and then once weekly for maintenance. I have them follow up at 6 weeks. I send them home with the printout of instructions, and show them exactly how to do it. And it rebuilds the estrogen. It plumps up the cells so they're not as thin and fragile. And it makes it more like the premenopausal state. So they're really great options for sexual dysfunction, recurrent UTIs, recurrent yeast, and just general vulvovaginal pain. Hormone replacement therapy. So we used to say only up to 5 years use. However, that has changed. You can use them longer than 5 years, but the least likely to cause adverse effects is when you start it within 5 years of symptoms. So if you went through menopause at 52 and you're now 72 and having hot flushes, it's not necessarily appropriate to put a patient on hormone replacement therapy, unless it's been going on all along the way and you've done other workups to rule out other causes of hot flashes. There's systemic pills, patches, sprays, gels. You can put gel, rub it into like your thigh, and it'll give you different relief. Estrogen versus estrogen and progesterone. So if a patient has a uterus, then you need to give them progesterone with the estrogen to help thin the lining out. Because like going back to our menstrual cycle, in the beginning, estrogen goes up, then progesterone goes up, and that thins the lining and causes you to have a period. When you're postmenopausal, you do not have a period anymore. So you can't just keep giving estrogen and not progesterone to thin that lining so that it doesn't build inside. So if there's a patient who didn't have a hysterectomy, they have a uterus, they should get estrogen and progesterone. Some docs will also do testosterone. It's not as common, but some will do it, especially if a patient's complaining of like decreased libido or energy. It can decrease hot flushes, protect bone health, relieve vaginal dryness, improve sexual function, and it can help with sleep. It also can help decrease the risk of uterine cancer, the progesterone part of it. Mild adverse effects, some women notice breast tenderness. They're like, I feel like I'm getting my period, I'm tender, or I have cramping. They can also get bleeding, and they shouldn't get bleeding. If they're getting bleeding, they need to let your doctor know, and you may need to stop it. It may just because the lining's dysfunctional, but it needs to be investigated. And they usually do an ultrasound where they look at the lining, because that's not something we can see on exam. The ultrasound shows the endometrial lining, and in a menopausal woman should be less than 4 millimeters. If we know that, then with 98% confidence, we know those cells are not abnormal. So if the bleeding stops, you usually don't do anything. If the bleeding continues or the lining is thickened, then you might have to have what's called an endometrial biopsy, where your doctor puts in a little tube in the office and pulls out a few cells. It's not fun, but it's a couple minutes, and usually takes some ibuprofen before, and that's 96% sensitive in picking up endometrial cancer. So that's why we do that. We have to be cautious with these medications. Serious side effects usually occur within the first year. So that's why the patients have to be monitored closely. Like, I'll tell my patients, I'm going to see you in 3 months, and then I'm going to see you every 6 months. And sometimes they get frustrated. Oh, you just want my copay. I'm like, no, I want you to be healthy and safe. And these medications are not used to be taken lightly. So I create an individualized care plan for the patient. And I want to make sure that I'm not doing harm on them. I don't want to give them a problem they don't have. I want to help their daily life so they can get through the day and feel better, but I don't want to cause a problem. So some patients can have thrombotic events like blood clots in their legs or lungs, a stroke, cardiovascular events, breast and uterine cancer. No, so those are very scary things. And that's why we usually use the lowest dose. Also, I usually use a patch now because it has a lower side effect for blood clots than the pill does. In combination, that's for estrogen, with a progesterone pill to thin the lining. And I watch the patient very closely, especially for the first year. Okay. And you should also be telling your primary care doctors and anyone else that you're on these medications. So patients who have pre-existing hypertension, if they're smokers, if they have a history, a personal history or family history of blood clots, I'm not going to be putting them on hormone replacement therapy. So that's why we have to think about maybe the non-hormonal options for them. Patients who have active breast cancer that's hormone sensitive, like estrogen and progesterone, that means giving them hormones would feed the cancer. So we don't want to give patients who have that type of breast cancer systemic hormones that go through your body. talked about the vaginal creams. They're great options. And then there's also selective estrogen receptor modulators. So these are great options, but they often disguise themselves as non-hormonal. But what they are is precursors of hormones. So they can activate hormones. So we do have to be cautious that they can still activate the tissues, build breast tissue, build endometrial tissue, and they do cause a vaginal tissue proliferation, which is nice that they can, like intrarosa goes vaginally, and that is DHEA. So it's a different precursor of a hormone, and that can build the lining up. So you have to find the right patient, and that's why the doctor has to take that extra time with you to find out if you're a good candidate for hormones. Hormone replacement therapy and cardiovascular disease. There's been studies back from the Women's Health Initiative back in the 70s, and there was concern, is this going to cause congestive heart failure or cardiovascular disease in women? Well, a lot of these women get these diseases because of the lack of estrogen. So there's been decades of conflicting data. However, the 2015 Cochrane review concluded that HRT should not be used solely to prevent it. However, that is an added benefit. There were 19 trials. So women do have a slightly increased risk of stroke, DVT, and PE. So it's not just, hey, we should put everyone on it because we want to protect their heart, or we should put everybody on it because we want to protect their bones. Those are added good effects of these medications. However, we can't deny that some patients shouldn't be on it because of perhaps their increased risk of stroke or blood clots. Okay, but what they found was that if HRT is started less than 10 years, particularly less than 5 years from the onset of symptoms, then it does have an overall decrease in coronary artery disease and decreased mortality. Also less risk of clots. So just briefly, I'm going to go through this because I only have a few minutes. Cardiovascular disease, it's overall leading cause of death in women in the United States. And strokes actually can be more common than heart attack in women. Symptoms present very differently. Some women get more of like abdominal symptoms, or they get atypical chest pain. So it's not something that should be ignored. These are the risk factors here. So just take a look at those. Hormone replacement therapy, if patients are smokers, have a family history, or they have pre-existing hypertension. Prevention is key. You want to go to your annual well women visits. So even though we are primary care providers, we do not replace your general family practitioner or internal medicine doctor. You should go to them and have proper laboratory screening, mammograms by 40 unless otherwise specified, colonoscopy at 50 unless otherwise specified, bone density at 65 unless otherwise specified. Lifestyle changes and some medications to control hypertension, glucose problems like diabetes, and lower your cholesterol. Statins are actually cardioprotective. Osteoporosis, risk factors here. So females are 5 times more likely, Caucasian, smokers, thin women, they're a lot more likely to get it. So we usually start at 65. However, if you have 2 or more risk factors on this list, then you should be getting a bone density earlier. Same thing for women who went through menopause at 40. That's now 25 years that they have gone without having a bone density. That's a problem because they lost their estrogen 12 years earlier than the average woman. So they should have a bone density much earlier. Typically, if the bone density is normal, then you can get another one in 5 years. If it's abnormal, then you have to talk about what type of abnormal. So osteopenia is softening of the bones. So there are bones, even though they're hard, they're dynamic organs. They're constantly breaking down and building back up. But as we age, they break down faster than they build back up. So we need to do the bone density, which looks at basically 2 joints, like your hip and your spine, and gives a score. So T-score is what we look at. So the more negative you are, the worse it is. So osteopenia is a softening of the bones. Osteoporosis is when you actually have more severe risks of a major fracture. They also calculate the FRAX score. And if you have a high FRAX score, then you have to have more frequent testing, and you may need to be on a medication for osteoporosis. Some physicians that are gynecologists will manage osteoporosis. Others will refer you to an endocrinologist or your primary care provider, but they need to communicate with each other and with you. This is some of the prevention. So if you have osteopenia, or if you want to prevent osteoporosis, If you're postmenopausal, vitamin D, you should be getting 800 international units of vitamin D daily, whether it's from fortified foods, sun exposure, because that helps to convert the vitamin D into a usable form. And I'm not saying go bask in the sun for hours, but a little bit of sun exposure helps to activate the vitamin D. Also supplement with just a vitamin D supplement. Calcium, we want 1,300 milligrams daily for a postmenopausal woman. All right. Now, there have been some conflicting data about just taking calcium supplements because they could lead to kidney stones, and there has been some question about cardiac issues. So you want to get it as much from your fortified foods as much as possible, and then weight-bearing exercise. So as good as swimming is, it's not good for osteoporosis. You really want to do weight-bearing exercise where you're lifting or you're doing squatting or lunges, something where you're using your body weight, but you have to avoid falling, because with osteoporosis, which is easier said than done, osteopenia and osteoporosis, you're at much greater risk for fracture, and sometimes it's called a pathologic fracture, and you really see a big decline in women after that. And these are some of the treatments. So you shouldn't treat with hormone replacement therapy, but if a patient's on it, they may get benefit from it. And then these are some of the medications, which I'm sure you've heard of. All of them have side effects and they may interact. So you have to find with your doctor what's the best option for you. These are some helpful resources. If you want to take a picture of this slide, because it has the resources. So the first three are mine. ACOG, the North American Menopause Society, and the Mayo Clinic. Those are really good places to find evidence-based information about menopause. Read up a little bit more on what you can take a picture. It says the slides are off. Somebody's sending
The
that.
slides are off. Yeah, please. The slides don't correspond to what you're saying.
I'm not sure why that is. Okay. Can you see the helpful resources talk? The helpful resources slide?
No, there's a delay, but maybe we can give it a few minutes and see.
No, you're like way ahead. We're on special considerations for osteoporosis screening.
Okay, I'm not sure why it's not.
Yeah, I think there might be a delay.
Okay, well, what I'll do is, if we email them out the link to the talk, we can email. I'm fine with sharing my presentation. We can just do that. I'm not sure why it's delayed because I can see them and I'm sharing it, but okay, well, you can absolutely send my presentation out so they have it as a resource.
Perfect.
But thank you for letting me know that. So there's some resources here. I have some links, and then also Tara and Elena also gave me some links as well, and for their talks, and some health resources for behavioral health. So that's on the last slide here. So my contact information is there. It's vanessa.parisi, vanessa.parisi at Mountainside Hosp, so MOUNTAINSIDEHOSP.com. So vanessa.parisi at mountainsidehosp.com. If you have any questions, or if you want me to email you the slides directly, I can do that. But again, this lecture does not substitute medical treatment by your physician. If you're experiencing any health concerns, you should contact your gynecologist, primary care physician, or the appropriate specialist. So I'm sorry that the slides were delayed. I didn't realize that. What I will do now is, because we started about 10 minutes late, I'm just gonna forgo the break, and I'm gonna just mention Dr. Grover again. She's our endocrinologist for Mountainside Medical Group, one of them. And she's really sorry that she could not make it today, but she wanted me to say, I'm so sorry I wasn't able to join you all today due to a close family member's health, but wanted to give this gift of mindfulness before starting the session. We spend a good amount of time understanding our body, taking care of our body, but equally important is taking care of our mind. Being in the present, taking moments to rest and recharge. Our cells do listen to our thoughts, so please enjoy and hope to meet you all soon. I'm going to play the little meditation that she gave us. It's like 5 minutes, and I hope it will be a good transition into our behavioral health talk. Do we have questions, Fleury? Should I take those first?
Yes, we do have some questions. I'll read them off for you. If you gain weight, is it because of the estrogen?
If you gain weight, is it because it's more of the fluctuations in the hormone, because estrogen is actually declining. So that can be part of it, yes. Because it's just a time where the estrogen is housed in the adipose tissue and the fatty tissue, and it can be distributed differently around this time.
The next question, does everyone need to go on hormone replacement therapy? And if not, what else can we do to prevent issues with bone health and cancers that come up with menopause?
So hormone replacement therapy is definitely not for everyone. I hope with my talk that you could, along the way, that you could see that there are a lot of non-hormonal therapies. For patients who have symptoms of menopause, acupuncture actually has proven to help. And some of the SSRIs, the behavioral health medications, they can be shown to help. If you don't have, some women have no symptoms, so they don't need to be placed on it. And as far as, preventing cancers, you really need to go to your well woman screening and your well care screening through your primary. So making sure that going every year to your OBGYN, even though the PAP guidelines have changed and you're getting them maybe every 2 to 3 years now, you still should have an annual breast exam and an annual pelvic exam. Your mammograms are recommended at 40 unless you have a significant family history or a genetic predisposition. And then you should be getting mammograms every year. I know Medicare doesn't cover them every year, so that makes it tough. They cover them every other year. If you have a supplementary insurance, it may pick it up, but at least get that breast exam and get the mammos every 2 years then. Letting your doctor know immediately if you ever see a drop of blood postmenopausal. Most times it's because of vaginal dryness or an infection, or maybe you have a polyp, and polyps are 95% of the time benign, but in a postmenopausal woman, they should be removed. So just catching things early really helps to prevent cancer. Healthy diet and exercise, we're going to have our great talk on nutrition, is really important. And there's different ways to focus on it, because I'm 35. I know that at 25, I could lose weight a lot easier than at 35. I know as I age, it's going to be harder. And I have patients who tell me, they're like, I eat really well, doc. I exercise 5 times a week. Maybe you need to meet with a nutritionist. Maybe you need to meet with another doctor and discuss. Maybe you need to tailor your diet or tailor your exercise regimen to someone of a menopausal age, and it may work better for you. There's different modalities. So like if you're doing the same thing every day and it's not working, we need to change it up. So really prevention is key. Healthy diet and lifestyle hopefully will help to prevent things. And then if you do have something that happens, I mean, breast cancer occurs in 1 in 8 women. It's very, very common. If we catch it early, usually we can fix it. Getting your pap smears, getting Gardasil vaccine if you're, under 45, those types of things can help prevent HPV-related cervical cancer, which every cervical cancer is HPV-related. There's a lot of, that's why we're here. We're here to educate you. Please ask your doctors questions. We want you to ask questions. We want you to advocate for yourself. And I'm not saying don't read and do your own research. I just want you to have the good resources to find the information.
That's great.
Any other questions?
And one last question. If you go on some sort of treatment and then stop, do you go through the perimenopause symptoms all over again?
Some women do, some don't. Some, their body just kind of naturally comes out of it. Other women stop hormones and it comes back with vengeance, and they have hot flashes. So they may have to go on an alternative therapy or go back on it. But the best thing to do is wean it. So that's why I always try to do the lowest dose. So if I do an estrogen patch, I'll do a low dose, and I only work it up if I need to, so that when I go to take the patient off of it, it won't be as difficult. Or you can go from a higher patch to a lower patch and wean off. Also, the SSRIs, if you're on them, you should never stop them abruptly. They need to be weaned. So you can work with your OBGYN or your behavioral health specialist, and they can help you transition.
That's great. And that's it for now, Doc.
Okay. Great. So let me play the mind. Is everybody seeing Dr. Grover's slides since it's been a few minutes?
Yes.
Okay, so hopefully, let me see if this will play. Got sound, so at the very least you can hear it. There's not much to see on it. Maybe. Get it this way. Um, Playing Dave Matthews, not her. All right, let me see what's here. I don't know. Sorry guys, let me try to get this back.
I can see it. I'm not sure if I can hear it. I don't hear it. Let me.
Is it coming from the doctor's screen? Because if so, she's muted, isn't she?
Correct. I'm trying to unmute her right now.
Okay.
I know.
Okay. Thanks. Team effort, team effort. Let me try again. Okay, can you
Yeah.
unmute me? Okay, good.
Yeah.
Can you hear it now?
No.
Could anybody hear that?
No.
No.
Maybe
Okay,
Doc,
so I
maybe
think
we
what we'll
can
have to
share
do
the
is we'll
link.
just send it out.
Yeah.
Yeah, we'll share the link. When I send out my, because she went through the trouble of making it for everybody. So we'll
Yes.
move on to the next talk because I don't want to hold anyone up. And let me unshare my talk. Sorry about that, everybody. And we can go on to, we're going to go on to Tara.
Tara's correct.
Yep. Tara, are you able to share your slide? Okay,
Yeah.
perfect. I'm going to
Yeah.
mute myself. Thank you, everybody, for listening. I'll be back in a bit.
Thank you, Dr. Parisi. You were wonderful.
So good morning, everybody. My name is Tara Fries. Hopefully you can hear me okay. And thank you, Dr. Parisi. You shared so much good information. I feel a lot smarter than I did yesterday, so thank you so much. So today I'm going to talk to you a little bit about mental health for women over 50. We're going to talk just briefly about, women over 50, some specific issues that you may be dealing with, signs of depression, and what you can do. And then at the end, I'm going to give you a list of resources. Dr. Parisi had also shared them, but I'll share them once again for you. So we know, as Dr. Parisi mentioned, perimenopause can begin as early as in your 40s, can move into your 50s, can last anywhere from 10 plus years. And the symptoms can really range in severity. So, somebody can be experiencing very, intense symptoms for a long period of time, or none at all. You may have abnormal menstrual cycles, intense mood swings where you're having some real highs, some real lows, irritable mood, so flashes of anger, things are bothering you that don't normally bother you, hot flashes like Dr. Parisi spoke about, and sleep disruptions. So a lot of these symptoms might be really uncomfortable and unsettling for you, and they can also appear as if it's a mental health issue. So specifically like depression, it can look like anxiety, and in some cases it can even look like bipolar disorder. So it can kind of leave you feeling like, what's wrong with me? Am I losing my mind? So Dr. Parisi had also shared some kind of funny, not so funny memes. I had picked out two that I thought were kind of cute as well. The first one, I'm a victim of identity theft. Menopause took a happy, slim, sexy woman and turned her into me. And the other one is, my greatest fear is that menopause doesn't exist. This is the real me. So I think any of us in our 40s or 50s has sort of had those moments like, is this really what's happening to me? Or is this, menopause sort of taking over my body? And, the truth is, women, in their 40s and over 50 are often confronted with a lot of overwhelming issues that can cause a depressed mood, also anxiety, and sort of these mood shifts that we're talking about. So, we talked about the hormonal changes, and by no means are these issues the only issues you could be dealing with. I mean, there's a whole host of other issues as well, but these are some of the bigger ones that tend to sort of happen in this age frame, this time period for women. So, like we said, hormonal changes, we're dealing with low energy, possible weight gain, irregular periods, career insecurity. So you may be questioning your job, but you also may be faced with sort of this younger workforce that is, coming up and maybe younger, more energetic, a little less expensive. So all these things that, when you're sort of in your middle age, you might be faced with at work. Changing family conditions. So you may be at this point faced with some marital issues. You may be contemplating divorce. We know that during this time period is a very common time where people do tend to end marriages. You may also be faced with being a widow as well. If you have children in the house, some of the children might be in their teenage years, which we know it can be a very challenging time. Or they may be on their way out, moving out, going to college, or just leaving the house. So again, leaving you home with your partner to sort of address any marital issues that may have been existing there for years while your kids were in the house, and now you're sort of left with this person having to deal with, okay, our marriage that we haven't really paid attention to for the last 15, 20 years. And then finally, caregiving. So we might be having to deal with older family members who are developing some medical issues, or even dealing with, the death of an older family member. So again, like I said, these are not all of the issues, but these are just some of the bigger ones that you may be confronted during this time period. So all of these things, one of them can cause sort of a depressed mood, but if you're dealing with a few of them at the same time, definitely can be causing some depressed mood, some anxiety, and some irritableness as well. So you may have wondered, there may have been times where you may wonder, am I depressed? Am I actually depressed? Or is this just something that is going to clear up shortly? So these are really the signs that you want to be looking for as far as, are you clinically depressed? And of course, like Dr. Parisi said, you want to try to avoid to sort of self-diagnose, but it is also important for you to be aware of your mood, what your typical baseline is as far as your mood, and any changes above or below the baseline, right? So if you're having a bad day, one day, here or there, it doesn't necessarily mean you're depressed. What we look for is if you have, say, 5 or more of these symptoms, and you have them lasting for about 2 weeks or more. Okay, so again, if you're having, a bad day, you're feeling sad, you're crying at a commercial, you're just really, upset for, no reason, that's okay. Even if you have 2 days like that in a row, this isn't a big deal. It's when you have it day after day after day, and you really notice it for about 2 weeks straight. And it starts to really kind of impair your functioning. So you're having trouble making meals at home. You're having trouble getting up and going to work. You're having trouble with relationships. When it's impairing your functioning, that's when you really need to start to think about, okay, am I really depressed, or is this something, is something bigger going on? So some of the symptoms are feeling sad, hopeless, and helpless. So, are you crying more often? Are you feeling like, oh my God, this is never going to get better? Feeling like you have no power to make it better. It's always going to be this bad. I'm always going to feel horrible, without having sort of, this idea that, this may pass, but just more of this kind of hopeless feeling like I'm always going to feel horrible. Irritable mood, like I said before, where things sort of bother you more than they normally would, or you're getting angry, and the anger is really in this sort of intense way. Lack of joy, that sort of looks like, things that you would normally do that make you feel good, getting in the car for a drive, listening to music, maybe gardening, all of those things that you typically would do on a normal day for yourself, just don't feel good to you, and they're not appealing to you, and they're not helping. Low motivation and avoiding behavior. So what does that look like? That means I'm lying on the couch for 5, 6, 7 hours, scrolling on my phone. I'm not doing anything. Things aren't getting done in the house. I'm avoiding, people are calling. They want to make plans, have coffee, and I'm just not answering the phone. And I just keep making excuses that I don't want to do anything. And again, there's always going to be those times where you just don't feel like doing it, and that's fine. It's just when there's a pattern of it. Difficulty with memory and focus and concentration. So you're having you notice that you're having difficulty remembering things, you're having difficulty sitting for maybe a half an hour TV show, or you're having trouble even kind of reading through a passage in a book or in a magazine. Because your head is just is filled with, so many other thoughts. You're worrying about too many other things. Change in energy level. So either you're very restless, maybe your legs are shaking a lot. You feel like your body is you can't get comfortable in your own skin. Maybe you're pacing around a lot, or sluggish. You're not moving, you're sleeping, more. Self-harm, suicidal ideation. So self-harm we see more with our teenage population, but if there's any type of cutting, and suicidal ideation, if you're starting to have thoughts of, I don't want to do this anymore, I would rather just go to sleep and not wake up, or really having thoughts of how you could potentially end your life. These are definite signs of some depression. and then a change in eating or sleeping pattern. So, eating or sleeping too much or eating or sleeping too little. Okay. And really depression, depending on the person, depending on their age, depending on their culture and their history, can really look different in different people. So it's about knowing yourself and knowing sort of what you typically are able to do and want to do, and what the change is. Like I said, if your baseline is here, if you're acting in a way that's elevated or too low for a 2-week period, then it's something you want to just be aware of and maybe possibly talk to your doctor about. So what are some of the things that you can do to sort of help yourself if you're not feeling, if you're feeling depressed and anxious? So the biggest thing I can say, and we all talk about this and we all hear this, from everywhere, from doctors and everywhere, is eating, sleeping, and exercising. Sleeping, to me, is probably the biggest thing you can do, is really having a good night's sleep. So whether it's 6 to 9 hours of solid sleep. I know a lot of us wake up in the middle of the night to use the bathroom, or if you are being bothered by hot flashes, but really trying to get a chunk of sleep, because that will alter your mood the next day and your energy level. So that's probably the number one thing you can kind of focus on, is trying to make that a priority, is your sleep patterns. Eating 3 meals a day, exercise. When I talk about exercise, I'm not saying go join a gym. I'm saying go outside, move around, move your body, get fresh air. If you can do it for 5-10 minutes every single day, even if you're just sitting outside just to get some fresh air. But a lot of us have been working from home, we've been inside more, so now is the time to get out, to move. Any type of movement outside is helpful for your mood. Taking your medications daily, getting routine checkups. So just maintenance on your body, making sure that physically everything is kept up to date, that you're getting your checkups, really important. Maintaining healthy relationships. So, making sure that you are staying connected with your family and friends that make you feel good. But if you have, we all have those people in our lives that, you get off the phone with them and you just feel like they sucked every ounce of energy out of you. So really minimizing those relationships, so that, oh, I don't know if did we lose something? I don't know if I just lost, sorry.
At the top, it says resume slideshow. Maybe you need to hit that.
Oh, I'm sorry.
I don't know if that will work or not, but try it.
Let me try. I don't know what happened. Sorry, guys. Here we go. All right. I'm so sorry. And sticking to a routine. So sticking to a routine really means structure, having structure. So, and particularly Monday through Friday, making sure that you have a good wake up time. You may have a routine in the morning, you have your coffee, you brush your teeth, you take a shower, you get dressed. And at nighttime, you also have a bedtime routine, right? So maybe you do a quick meditation. You have whatever it is that you like to do at nighttime. You brush your teeth, you get your pajamas on, you sit in your bed for a few minutes, you read a little bit. But really kind of sticking to a wake up time and a sleep, a bedtime. During Monday through Friday. On the weekends, you can kind of let it go a little bit, but really creating that structure for yourself and for your family and the household is important. And then lastly, limiting substance use. So I'm not going to say don't ever have a glass of wine or do anything. Just be aware of your usage. So am I drinking more often? Am I drinking more than I normally would? Knowing yourself, knowing how much you can handle. and just making sure that, if you're a social drinker and you find yourself drinking every night to kind of, help you go to sleep, that's something that should raise a flag for yourself. So the substance use, the alcohol, and anything else that you might be using is only going to make things harder. It can create additional problems for you, and it will definitely impact your mood. So a lot of people will say, oh, I wanted to just relax, I had a glass of wine, but the next day you will be more depressed. It is a depressant. So you have to always remember that, okay? So moving on, so Dr. Parisi talked a little bit about mindfulness. I know we weren't able to see the video, but just a few quick things that you can also practice on your own. So, and the overarching idea with mindfulness is, to be present in the moment, right? And it's hard. We're always thinking about all the different things that we have going on in our lives. But really to try to stay present in the moment, to ground yourself. And that way your thoughts aren't getting too far ahead of yourself, which a lot of times doesn't help with the depressed mood and the anxiety, right? So journaling is helpful, breathing techniques, visualization. If you can go into your mind, close your eyes, think about a happy place maybe you went on vacation. If you're a beach person, you imagine yourself on the sand. If you're more of like a woodsy person or a city person, you close your eyes and you actually bring yourself to that place, and you will feel your mood and your anxiety immediately sort of start to go down. So and it's something you really need to kind of practice. Gratitude. So that's really about, making sure that you're identifying things every day that you're grateful for. Not just looking at the negative, but really looking at the positive. Some other things that are really helpful: adult coloring, handcrafting. So anything with your hands, right? Knitting, crocheting, cross stitching, anything like that where you're keeping your hands busy is very helpful for your mood. Any kind of movement, yoga, tai chi, dance. These are some apps that are helpful. Calm, Headspace, I believe you have to pay for those, but there are guided meditations like the one that we were about to see on YouTube. There are tons of them out there, so feel free, go onto YouTube, find one that that you really like, that feels comfortable, and just keep doing it. And the more you do it, the more comfortable and easier it gets for you. There's grounding techniques. So if you're feeling anxious and overwhelmed, there's the senses tool where you in the moment, you say to yourself, I see 5 things. I see my computer, and you list those 5 things. I touch 4 things, and you actually touch them. You hear 3 things. You smell 2 things, and you taste 1 thing. So you go through that technique, and it's a way to kind of bring you back into the present moment. Also tapping, the repetitiveness. So you tap your legs, you tap the surface in front of you. Those things will all help sort of bring down your anxiety and your mood, help with affect regulation. So what happens if you're still struggling? You've tried all these things, you've tried all the tools, you've gone for walks, you've done all those things, and you're still really having a tough time. So find a therapist, find a psychiatrist. There are a lot of medication options. Dr. Parisi mentioned a bunch of them. So talk to your doctor about starting medication. A lot of the antidepressants will take anywhere from 4 to 6 weeks to really get the full impact of them. So, don't wait. If you really are finding that you're struggling, talk to your doctor and start the medication, and you will see they're very effective. And then finally, if you're having thoughts to really hurt yourself and you're finding that you're having these sort of intrusive thoughts during the day, call 911 or bring yourself to the emergency room and get evaluated, because you might need to have a little bit of inpatient treatment. So At Mountainside, we do offer, here's a list of our resources. The first one is the outpatient department. So that's really if you wanted to set up any kind of individual therapy. But at Mountainside, we also do have a crisis department in the emergency room. So if you're having thoughts to hurt yourself or somebody else, you would bring yourself to the emergency room, have the police bring you down, an ambulance, and they can evaluate you. And if they feel like you need to be inpatient, they will bring you upstairs. We have an inpatient unit, and they will, you'll see a psychiatrist, you'll see a medical doctor, and they will really help to get you stabilized and then discharge you. And then these are a few other resources. Mobile crisis. This is if you have a family member, say, who's having some suicidal thoughts and refuses to go to the hospital, you can always call that phone number and they will actually come to your house to evaluate the person at your house. And then, of course, the crisis text line and a warm line. That's just for if you're feeling out of sorts, you want to talk to somebody. It's not 24/7. But it is there for you. So I want to thank everybody for joining, and that's the end of my presentation. So thank you again for your attention.
Thank you so much, Tara. That was a wonderful talk. That was very, very helpful. Do we have any questions, Lorraine?
Nope. Not any questions right now.
That means you answered everything. That's great. Thank you so much. Again, we'll be sending out the slides with the resources so that you can see them. But I really think that, as I said before, mental health takes a role and manifests in the body in so many ways. So I think we were very fortunate to have you here today, Tara. Thank you.
You're welcome. Thanks for having me.
And then Elena will be next because we're a little short on time. So we're going to skip the break. If you need to take a bathroom break, feel free to do that and come back. But as far as Elena, do you need us to share your slides for you?
I think I can do it. I will try real quick. If it works, if it doesn't work, then doctor, if you could do it, it would be, but let me try. Okay, fixed it. Is it sharing my screen now? Let's share. Almost.
We don't see anything yet.
You don't see anything yet?
No.
Do you want me to do it and just say slide or?
Yeah, that's fine.
Oh, it looks
There
like
you
it's
go.
starting.
It
says it's starting to share context. I think you got it.
Okay. Let's see. Can you see?
Nothing.
Oh, okay. Why don't we just, for time purposes, doctor, if you could share, and we will go from there. And this is good. You can help speed me along.
Okay, can you guys see?
There's definitely a delay of some sort. We just have to be a little bit more patient.
I can try.
It's coming up.
Okay, good.
Yeah, I have a
Okay.
slideshow on.
So I'll introduce myself while we wait for the slides to come up. My name is Elena Mills. I'm, as the doctor said, a registered dietitian nutritionist. I am currently the clinical nutrition manager over at Mountainside Hospital. Some of you may have met me before, come to another presentation that I've participated in with Flore, but we are going to talk about nourishing our bodies as we get older. And I think it was awesome how, even from what the doctor was saying, from what Tara was saying, nutrition and movement really play a role in just keeping our bodies healthy and helping our body support our bodies through all the changes of our lifespan. Doctor, if you could slide us along. Thank you. So as previously spoken about, we have osteoporosis. It's very important that we work on strengthening our bones. 5 to 20% of women over the age of 50 are estimated to have osteoporosis. Caucasian women, it's more prevalent, but it is also found in a wide variety of everyone. 35 to 50% of women over the age of 50 are estimated to have low bone mass. So they have not yet been diagnosed with osteoporosis, but they are finding that they have lower bone mass. You can see pictures down here from the one where you see less holes or they're tighter together. It's more dense of your bones. That's when we're younger. And then as we get older, you can see that the bones become more porous, and that's where they become more fragile. And we are at a higher risk of fractures. We also, as women, are at a higher risk of lactose intolerance. And doctor, if you could slide, you'll see calcium plays a big role in building our bones. Since we are infants, our bones are constantly breaking down and then rebuilding themselves. And calcium is part of that building block of building healthy bones. So it is important. Vitamin D helps to absorb that calcium. We need about 600 to 800 IUs of vitamin D daily. The safe upper limits, I know sometimes our doctors prescribe a little bit higher IUs, or your dietitians. 800 is where it's our average what we need, 600 to 800. Calcium, we need about 1,200 milligrams of calcium daily. Sometimes a little bit more. I think Dr. Parisi said 1,300. Where do we get these calcium from? Milk, soy milk, dark green leafy vegetables, fortified orange juice, fish with bones. So our sardines, some canned salmon has bones in it. That's where we're going to get our good sources of calcium. And then if needed, supplements. Supplements, again, you want to talk to your dietitian, you want to talk to your doctor about ever taking a supplement, because it may interact with other medications that you're on or may have other side effects as well. Next slide, please. So from the time that we're small, I know myself, my mother has always told me to keep a constant eye on how much calcium that you're taking. And when I still see the calcium slide, but I'll just continue to talk about it. When we say we need 1,200 milligrams a day, you want to spread that out. Our bodies won't absorb 1,200 milligrams at one time. It absorbs about 500 milligrams at a time. So if you are taking a supplement, or if you are having a glass of milk, then you want to have another dairy product or high calcium product later on in the day. So you want to split up the amount of calcium you're getting in your day. Next slide.
I'm on the sarcopenia.
Oh, I'm seeing calcium. Let me see.
Much.
I'll go. I can. So I'll talk about my slides, as the doctor was saying, with if there's a delay. You want to build and maintain our muscles. As we get older, our bodies begin to lose muscle mass. When we are about 30 years old, we begin to lose our muscle mass. 3 to 8% of our muscle mass we lose every year, starting at the age of 30. So sarcopenia is the natural loss of muscle mass as we age. Older women, not just women, but most everybody, as we get older, we're sitting more, we're exercising less, and we are losing our muscle mass because we're not exercising as much, and just the natural process. By the time women reach 80 years old, they have lost as much as 50% of their skeletal muscle mass. So it's important that we help our bodies to keep them strong, to maintain our muscle mass. So we know naturally we're going to be losing this muscle, so we need to help maintain it. As we lose our muscle mass, we lose our ability for our gait balance and for our stability. So it kind of, as you see, it all ties in. So if we're losing our muscle mass, we're at a higher risk for falls. And because we have decreased bone mass, we're at a higher risk for fractures. So it's really important that we work on maintaining a good, healthy nutrition, diet to maintain our calcium, to maintain our protein. Next, we'll talk about the protein to help with this loss of muscle mass. As we get older, when we're younger, we need about 0.6 to 0.8 grams per kilogram of protein for our bodies. As we get older, we need about 1 to 1.5 grams per kilograms of protein per our body weight. So in this slide, I'm kind of giving you an example of how to calculate this. I get a lot of questions. So if you see a dietitian, they will help you to calculate the amount of protein that you need per day. So this is an example that if you're home, how you can do it yourself. So over here, the example is somebody who weighs 140 pounds. 1 kilogram is equal to 2.2 pounds. You want to divide that by 2.2, you get 63. 63 times 1 to 1.5, this person would need 63 to 95 grams of protein a day. So where are we going to get our protein from? We want good sources of protein, high biological protein sources. They're found in dairy, meat, fish, eggs, legumes, quinoa, barley, nuts and seeds. There's more evidence-based showing that we are trying to reduce a little bit the amount of meats that we're eating and trying to get some proteins from plant-based as well. So that's your quinoa, your barley, your legumes. So in saying this, it doesn't mean don't eat any meat, don't eat any dairy, don't eat any eggs. I get a lot of questions on that frequently. It's just we want a well balance of all of these protein sources. As we get older, we also tend to be at higher risk for malnutrition. So with higher risk of malnutrition, it is related to muscle wasting. And this also is a reason why we need to ensure that we're having good protein sources. So then a lot of people are always asking me questions about weight gain. When we're going through menopause, we're having so many hormonal changes, as the doctor was saying, relates to some weight gain. And I hear frequently that, oh, I'm watching what I'm eating. I'm eating really healthy. I'm still not losing weight. I'm gaining weight. Sometimes when we think we're doing something, it may not be exactly what's happening. So something I always recommend is to write down what you're eating. 1 week, doing a great 1 week journal of writing everything down. When I say everything, I mean everything. Did I have a Hershey Kiss walking through the kitchen? Did I have an extra orange that was sitting on the counter? I was a little bit hungry and I grabbed an extra orange. So you want to write all of this down, and you want to, you can do it yourself or make an appointment with the dietitian, go over it with your physician, to see how many calories you're actually taking in for the day. Sometimes we think, oh, I'm only taking 1,200 calories for the day. But when we write down what we're consuming, we find out it's actually a lot more than we thought. So this is some estimations of what the calorie intake as we get older, 50 plus, is. 1,600 calories if we're not active, 1,800 calories if we're moderately active, 2,000 to 2,200 calories if we're very active. Again, this is estimates. Everybody's body is different. Some may need more, some may need less. So it's really finding a balance. It doesn't mean that we have to calculate all of our calories throughout the day. It's being mindful of what is in the food items. We start by taking a food journal, and then we can read our food labels and make the changes as needed. The next slide is on the dietary guidelines for Americans. This, the doctor also, it's part of our slides and our resources. It gives you a whole bunch of information. I get a lot of questions about what does that mean? So 1,600 calories a day, what does that look like? So this is showing us for someone consuming 1,600 calories, it's about 2 servings of vegetables, 1.5 servings of fruits, 5 servings of whole grains. We want to have more whole grains in our diets. Dairy, it's about 3 cups of dairy a day. Protein foods, 5 ounces of protein a day. You want to limit your oils and your fats. So that's just a little bit of a diagram of what is needed, what is recommended. But again, everybody, it varies. Everybody's diet and everybody's needs change. Vitamin B12 is an essential vitamin which helps maintain healthy red blood cells and promotes brain function. We find as we get older, there's a decreased absorption of this vitamin. It's found in our diet, but it becomes times as we get older that we may need a supplement to maintain proper levels of vitamin B12 in our diets. If we're vegans, a lot of vegans they're finding are at risk for having low B12 levels, so they may need to have a supplement as well. Fortified cereals, a lot of our cereals are fortified with this vitamin B12 to help us ensure that we're maintaining proper levels. And then, as was said by Dr. Parisi and by Tara, we want to get up and we want to get moving. As we get older, to help our, I'm sorry? Oh, as we get older, we want to maintain good weight-bearing exercises. So that's walking, dancing. So as we're using our bones, our bones are breaking down a little bit and then they're building themselves back up, which is helping them to get stronger. Also, strength training. We want to lift some weights, little weights, even if we don't have weights. Cans, bottles of water we can use to help us strength train. Using our body weights, doing some push-ups against the wall are important ways of maintaining our muscle and our bone health. And then I always find it amazing how it all ties together. And then with the behavioral health, dancing, walking with friends. Myself, there was a time when I was going to Zumba 3 days a week. I was up moving and it was so great for my mental health, just being able to enjoy myself and to get up and dance 3 days a week. These are all important and necessary ways to help keep our bodies healthy and strong as we get older. There is also, I'm sorry, a lot of groups that you can find in your local areas of getting together and walking clubs, dancing clubs, gardening clubs that you can help with this to keep your body moving. Any questions? I know I was trying to fit it all in so we maintain our time.
There's a question here. Does resistant bands qualified as strength training?
Resistant bands, yes. So you're using those muscles, you're working those muscles. Again, I just want to let everyone know I'm a registered dietitian. I'm not an exercise physiologist or a therapist, but yes, you want to, those resistant bands, you're using those muscles. So that is a form of strength training. Yes. So you're building your muscle. But as Dr. Parisi was saying as well, we have to get out there to move. So it's weight bearing. So that's where you're walking, you're kind of, I don't want to say pounding, but it's getting those bones moving to keep them strong. And then we do the weight training to help with our muscle.
Thank you, Elena. I have now unmuted most of you. So if there's anyone who has any questions, or do you want to continue sending me your questions through chat, please feel free to do so. We do have another 5 minutes before the end. I have given you my email address, but I have also given you our link to all our events. So if you're interested in other events, please feel free to visit hackensackmeridianhealth.org/events, where you'll find not just our Mountainside Medical Center events, but also our sister hospitals. So if anyone else or wants to send a question, we're here. We have a couple more minutes.
I had a question.
Okay, good. Go ahead,
Yeah,
my dear.
I had a question. You might not have seen it. If you have osteopenia and you take the calcium and then you find your calcium levels too high, what are you supposed to do?
So honestly, I'm not sure what the calcium levels are or how much you're supplementing. I see this about the vitamin D3 level being 24. You can take just vitamin D by itself. There are supplements that have both together. And then I would just increase the fortified foods. As far as like the specifics on it, you may have to have other hormones checked to see why the calcium is so high. Maybe there is something along that feedback pathway that's making your calcium elevated. Maybe parathyroid hormone needs to be checked, thyroid hormones needs to be checked, because they're all they all work in unison. I'm not sure if Elena has any comments on
So would that be an
vitamin D.
endocrinologist? Would that
I
be
would definitely, yes, I would
Yeah.
speak either with your primary, but most likely an endocrinologist if it's a problem where one is so elevated. If it's
one is elevated, one is really low. So
right,
the doctor
most people, go ahead.
Yeah, the doctor had told, this is my mother, the doctor had told her to get off of calcium and vitamin D3. And she wasn't concerned the fact that the vitamin D3 level was so low. So I'm concerned because I think it should be higher than 24.
Right. We want it to be about at least 30 or above. And most
Right.
people in the Northeast are low, and we can see fluctuations even during the winter time. Vitamin D, they're finding new studies, it's linked to, it's associated with many different disorders, or they're finding not really a causation from having low vitamin D, but it may be associated with different disorders. So, I mean, at this point, if you're not satisfied with what the doctor mentioned, and I can see it sounds like that, I don't know if there was an explanation or a miscommunication or something, but I would consider having her see an endocrinologist, because they are gland specialists and they have a variety of other tests that can be done to see, okay, why is one elevated and not the other? Because so premenopausal, the recommendation for vitamin D is 600 IUs daily, postmenopausal 800, and that's premenopausal for calcium 1200, postmenopausal 1300 milligrams. So, there have been a lot of recent things warning us to not advise patients to be supplementing a lot with calcium, because like I said, it can cause issues like kidney stones and everything. But with vitamin D supplementation, other than the fact that it may, by supplementing that, it might boost the calcium a little bit more. I'm not sure why your mother couldn't take vitamin D, but I don't want to speak for her doctor who knows her history. So I would suggest, we have several endocrinologists in our group, Dr. Grover, Dr. Fernandez, Dr. Sherry. There's several others that you can see, and you can, I know they're all taking patients, and they're very good at what they do. So that might be the next step, is a consultation.
Okay,
And
great.
I have shared their website, so you can check that out.
Okay, thank you.
Pleasure. Any other questions?
Which doctor would do a bone density test? So any doctor can send for a bone density test. Usually it's your primary care physician, but when I see my patients for their annual well care, I always ask about their surveillance. So did you have a mammo? When was your last mammo? Have you had a colonoscopy? When was your last colonoscopy? If you hadn't had a colonoscopy and you're due for it based on your family history or your age, then I will give a referral to a gastroenterologist, because that's actually a procedure that has to be done by a doctor, versus a bone density, which is done by an imaging center. So you can have it done Mountainside, another imaging center, wherever you'd like, but that's actually will be done by a technician, and then the radiologist will read it, and then they'll send the report back to the ordering physician. So I would get it from whoever you really want to go over it with. I order a lot of DEXAs. I don't do a lot of treatment, because through Mountainside Medical Group, we have such great primaries and great endocrinologists that I usually leave it up to them for the osteoporosis treatment, but I will order it and refer the patient and counsel them. So that gives us a little bit more, at least to make sure that it's getting done. Because anytime I say, you should go back to this doctor and have them do it, life gets in the way. We're busy. I'd rather just give you the prescription for it so it can get done when I give you your mammo and ultrasound if needed. The only one that we're limited on, like I said, is the colonoscopy. So I'll at least give a referral to a gastroenterologist who can do that procedure, because you have to be under sedation for it.
Any other questions? I want to thank, of course, our speakers today. This is a wonderful group of women that I've had the pleasure to work with for many years. And I think today's presentation, as I joke with Dr. Parisi all the time, it sounds like my life in a 2-hour presentation. Someone who is over 50, it's pretty much dear to her what we talked about today, and the frustration of being a woman and not being able to understand the body. So I think today's presentation was amazing. I want to thank everyone for attending. I am going to be providing you with my email again. If there's any other questions, I'll be more than happy to share our presenters' information as well if anyone needs to speak to them directly. But we want to thank everyone for being here today. Go enjoy that beautiful day outside now. Let's go do what I've been told to do today, correct? Let's go exercise and walk and get out there. So thank you, everyone.
If you use Facebook, I'm posting the mindfulness video right now. It's just Vanessa Parisi DO. And then I'm going to send it out with my slides to the registrants. So sorry for the technical difficulties. And thank you so much, everybody. Tara and Elena, you're amazing. Thank you.
Thank you, everyone.
Thank you.
Bye.
Bye.
Bye.